Facebook live session for talking about the new protocols. I have Jay Lou here with me, along with Mark, and we're going to talk about what's been going on in the protocols recently with COVID. So for those who have never seen this before, it's just a chat. This is not us as medical directors saying what to do or anything like that. We're just talking through the current protocols and how they've affected us as medics. So yeah, with that, so what have you guys been, I thought the one we'd start off with was a conversation around what's been going on with the initial triage protocol about leaving them in place. So how have you been feeling about that? What have you, how often are you guys using it?
Walker, why don't you start with giving a quick overview on what protocol it is you're exactly talking about?
So we have the leave in place protocol. So we have if someone calls for COVID, and they call in saying that they don't have any other emergent complaint, and they want to deal, and they just want it to be transferred to the hospital because they think they have flu-like symptoms or they think they have fever or something like that, that we have the ability to just leave them there instead and not transport them to the hospital, which is something that EMS has never had the opportunity in New York to do before, right? To not have to go through the RMA process.
Yeah.
That's a very crazy thing to think about. So,
yeah, I'm actually hoping that kind of sticks around a little bit,
as we all do.
Giving us the capability of saying, this person probably doesn't need to go to the hospital, and I'm pretty sure there's protocols like this in other parts of the country, where if you call 911 and you don't actually need to go to the hospital, and it can be treated right then and there, or there's no real reason that you just want an assessment effectively, because that's basically what I'm getting most of the time. It's someone calling 911 because they want an assessment and not actually go to the ER. And this has become more and more prevalent recently with patients that I want to get tested for COVID, and they didn't really understand that we don't do that on the ambulance. So a lot of the times we are getting to those assignments and saying yeah, we can't really do that. But if you can do something for me within the scope of practice, then we'd be happy to do that. But mostly it's yeah, you don't need to go to the hospital, and you should stay here and go to an urgent care if that comes down to it.
Yeah, I think I've been wishing for a long time that was something that we were going to be allowed to do.
Yeah.
I don't know. I think a bunch of people, I can't remember how many people when I first told them about it was saying, wait, is this now for all calls that aren't emergent? Can we just have it for everyone and not just for COVID? But
yeah.
Have you used it?
So lovely.
Have you used it on an ambulance call yet?
Yes, I have. And actually, the workflow for it was pretty good. What they put out, that PDF, that printed sheet that they put out, was actually very useful for saying, yes, this patient should go to the hospital, or this patient should get a medical control contact, or if there's any question, to make a medical control contact, and then the criteria for just releasing them back to the scene or to their own residence.
How has it been received by the patient population?
The patient population are mostly, they are happy to be left at home, simply because they don't want to go to the hospital anymore. Then they simply have been calling 911 just to get the assessment from us, which we're happy to provide. We're capable of doing quite a few diagnostics in the field, not all diagnostics. So we have to always put the caveat we're not going to giving you an x-ray. So if that's something that you need, then you should go to the hospital for that. And that has been actually very well received and understood by the patients that I've encountered, at least.
Yeah. I'm sorry. Go ahead, Jay.
I think it gives the EMS providers the power to actually render that kind of care where they're able to reassure patients that they don't need to go to the hospital, because I think part of this pandemic's issue is that it's creating a lot of fear amongst the general population, and people are able to deteriorate very rapidly, right? And so identifying those people is important. And so those kind of interactions where you can go and provide that assessment and not further endanger the patient or their family by bringing them into the healthcare arena where they would be exposed to infections or COVID itself in the hospital is fantastic. It also provides us with the ability to kind of, filter the patients that are being delivered to the hospital. So the ones that don't actually need to be there aren't going to be getting there themselves.
Yeah. I have to say, I think a lot of people have been using it's been great to have it. I've only been able to use it once so far, but it's been the leave behind sheet's really helpful too. I have to say though that I know so many people who are also going with that and just like they're asking people with minor injuries like, do you really want to go to the hospital right now? Do you really want to be exposed to this? Like they're kind of like, are you sure you want us to transport you? Like you really don't want to sign the RMA? Which is something I guess we've always done in some way, shape, or form for elderly patients, but I think this is like now people. I remember the first thing someone asked me was, "Wait, do I need them to sign the RMA at all now? Like, is it something I should still get if possible?" It's been,
no, there's no reason to sign the RMA because it's not an RMA anymore.
yeah, it's such a. I when I was trying to explain to non-medical people, they didn't understand what the big deal was, and I was trying to say this is like the most groundbreaking thing that's happened in EMS in such a long time in New York.
Yeah, and it is like that. It's quite a bit of faith that they're putting into EMS providers, which is wonderful because I think we've deserved it for a long time.
Yeah. But I mean, Jay, I've been on so many calls with you where we've done the whole like, you're pretty like elderly, like there's so many things traveling around there. Come on, like, do you really? You sure?
It's going to be curious how they'll handle reeling that back in, though, right? So I think that it's going to be difficult to kind of decide what goes back in once we are done with this pandemic and what gets to stay and what actually was like discovered to be something that's really effective that we should keep long term.
That's a really good point.
Or they're just going to flip a switch like they did with the cardiac arrest protocol.
Right.
Nice segue.
We're getting there. We're building up to it. But yeah, no, it's I also think there's a real problem with the tail end of it, right? Because it's going to go from this massive we're overflowing hospital pandemic to we're starting to, right? There's going to be fewer people calling for the ambulance each day, at least from the initial uptick. And yet it's still going to be there, right? It's still going to be part of the protocol set. So when they actually finally do turn it off, if that's what they do, then it's not going to be like this big COVID's here, we're doing it, and now COVID's gone and we're not. It's right. It's this other piece. It's this kind of like slow and steady phase out. So
I don't know about the rest of you, but how has your call volume been?
It's an interesting comment. So I think that the nature of the EMS runs that we're getting is definitely dramatically different, which is odd. I think that the incidence of everything that we're used to having is still occurring. I think that people are incredibly reluctant to call EMS and even access the healthcare like arena at this point. Like there was a study that was published that cardiac issues / mostly talking about like STEMIs and AMIs have been down 40% across the nation. Right. And so that's not that they aren't happening. It's that 40% of people who are experiencing it are no longer accessing healthcare. Right. There's nothing that's changed in the society. Like all the stuff that was happening before is still happening. This was also seen in the Ebola epidemic, right? Like a lot of the death that was attributed to Ebola was not attributed to the disease itself. It was the fear that was created around the healthcare infrastructure. And so people who were supposed to be getting C-sections in the hospital because they had obstetric complications were instead dying at home because they were afraid to go to the hospital. And we can see that happening here as well, which is really interesting. How does that segue back to like the EMS stuff? What was that? I don't know how I ended up on this tangent.
That's interesting. My call volume has raised a little bit because I was seeing a lot more higher acuity patients. And then it has dropped off with like the lower acuity stuff, like the Alpha Bravo calls. Mm-hmm. And I've been getting a lot more like Delta and Echo assignments. And these are like true assignments. Like for some reason, COVID is causing everyone's comorbidities to basically come out and attack them. If the patient has like a cardiac complaint, it's usually because they have COVID and the cardiac complaint. And it's putting so much pressure on the cardiovascular system that it's expressing itself at that point.
Yeah.
I had a patient in rapid AFib from a little secondary to their COVID, effectively, because they couldn't keep up with their oxygen demand.
Yeah, I think they said, what were they saying recently? That they were having, someone said, some doctor was talking to us at one of the updates, and they were saying that they were having patients who were like 94% SpO2, and then in the ED, they were having them walk in place, right? Just next to a hospital bed, and it would drop to 80 so fast that it was like record breaking. So I'm sure that's having an effect on all sorts.
I'm actually seeing a lot of patients that are like that as well. They're sitting in the 70s on room air, and they're mostly okay in the 70s, which is kind of remarkable by itself. They're walking around, they're extremely winded, but they will kind of fix themselves a little bit over time, but obviously oxygen helps them out massively. And then we're seeing a lot of patients that are like rapidly deteriorating with any sort of exertion, like dyspnea on exertion, but to the point of respiratory failure. And that is like the point where you have to apply the non-rebreather with the nasal cannula at 25 liters per minute for both of them and hope that it catches them up.
The non-rebreather with the nasal cannula reminds me of when I was doing RSI training back when I was in paramedic school, because I haven't been able to do it since then, unlike some of us, Mark. And then I remember it was like the nitrogen washout. It was like every type of oxygen possible into it once. And that's the last time I remember ever doing something like that.
Yeah, and it's a lot of things like if you saw someone like 5-10 years ago putting a non-rebreather and a nasal cannula on someone, you would think that these guys are idiots. They have no idea what they're doing. And then it's like it became good medicine at some point when they realized, like, actually, yeah, this stuff actually works. Putting a little more pressure into the system with a non-rebreather on full blast and a nasal cannula on full blast is actually helping.
Yeah. I wonder how much of a difference it actually makes, like the nasal cannula being added to the NRB. But
it adds like 5 of PEEP. So you're actually getting a pretty good amount of pressure.
Oh, you're talking about a pressure interesting.
Yeah.
Okay.
So they're breathing in and they're getting a little more pressure from it as well, which is actually why they were recommending it in the cardiac arrest protocol, like putting a non-rebreather on these patients while doing resuscitation, because you are getting a little bit of PEEP from that NRB being on the patient.
Mm-hmm. Right. Yeah, I guess going back to the other point of what we were talking about with like people not wanting to go to the hospital, it seems to me like it's like a snowstorm.
Yeah.
Or like any other time where just people don't go unless they absolutely need to. And so they're just calling less. I mean, I know our volume, Jay's been watching a lot more closely than I have, but our call volume like has spiked a lot at the beginning, but then it's kind of starting to teeter off a little. I would say, though, they were saying in particular that it's like 4 times the number of cardiac arrests that we're normally dealing with and other stuff like that. So, I mean, one of our other friends went on someone who works with me, Matt, went on a call and like he had a cardiac arrest that the person was fine until like they got into the ambulance and then all of a sudden coded.
Yeah.
Just like he did not know it was coming at all. And he was completely attentive. Like he was the only one with the patient. They were showing no signs of it. And then they just
there seems to be a lot of sudden cardiac arrest associated with any sort of patient exertion. Like if you're getting them to walk to the stretcher or to the ambulance, there's a pretty good chance that they're going to code. So like try to minimize that as best you can.
Yeah. So that was it's crazy. I don't know, but anyway, all right. So one of the other ones I was thinking of talking about was with regards to the proning and everything else. So have you proned anyone yet?
No. A couple of people at my agency have, but that was in the in-facility setting. But I haven't actually done it in a 911 setting yet.
Right, because they're really talking about, for us, I mean, I think, Jay, you read it just yesterday, or you were telling me about it. It's the proning itself is moving it around, having someone, they have to self-prone, right? So we can't prone them as they might in the hospital where you're helping them do it, right? If they can't move themselves in that position, then...
So I believe that the hospital utilizes prone positioning exclusively when patients are fully vented already.
Yes.
So it's an interesting thing for us to be doing it in the field without having these patients vented. And so that kind of, I think, goes back to why sorry, I'm just reading the questions on the side. I think that goes back to like why they're having the patients voluntarily move themselves into prone position. Because normally in our normal protocols, having a patient prone is position of asphyxiation, right? So,
Yeah.
I mean, I feel like it's a thin line now.
Yeah. Well, we just got a comment from someone we know. Aaron writes, I believe you're talking about about nasal CPAP. I wonder if the same principle applies with the NRB nasal cannula combo.
Yes, it does to a certain extent. Not as well as nasal CPAP, because it was actually designed to basically seal off the nares, but you get some level of PEEP out of a regular non-rebreather and a nasal cannula.
Yeah. Yeah, I guess they're just, I mean, since we're now only oxygenating and not ventilating any patient unless we're using those types of BVMs with the filter on it, it's crazy. By the way, have you seen the actual filter, the tiny HEPA filter that they clip on from the
Yeah,
XLR?
they come with our vent circuits, actually.
Oh, wow. I mean, I read when the AHA came out with the new policy about all this, it was pretty much like the moment you get to a cardiac arrest patient, do nothing, just walk in, tube them with a cuff tube no matter what, isolate the entire airway system, and then anything that gets exhaled is like, they were talking about like inline suction tubing and everything as well,
which is awesome. Like if you have one of those catheter systems for inline suctioning, use them. They're amazing.
I've never had one. Jay, have you done inline suctioning?
No.
It's a piece that fits into, it's like tied into it's on the top, right? So it allows the suction to stay permanently inside the ET or be able to be advanced into the ET tube and back out.
Yeah.
Without
so it's like a sleeve tubing.
Yeah, that's right. I wonder like how many EMS agencies even have access to something like that, let alone if they didn't have it before the protocol came out, or able to like acquire one in time.
Well, I think like HEPA filters are on back order for like until next year or something like that. It's kind of crazy.
Yeah, I actually saw one recently. They're talking about reusing. They talked about reusing N95s through some sort of compressed. What's it called? What do we use when we want to get rid of blood stains on the ambulance? The hydrogen peroxide. Sorry, when they were using some sort of like aerosolized hydrogen peroxide inside of a cabinet that they can like redo the N95s with. We're not condoning this. I just heard that they're like in development with this with some military grant right now to try and get that out and like get it going. But
as far as I know, Stony Brook has a setup where they can re-sterilize N95s. I don't know the process that they actually use it with it though. Yeah. I don't think it's a chemical process. I think it's like a heat process.
Yeah. No, it's I just read that one article about, but I haven't seen it implemented anywhere. But yeah, like the ventilation stuff now, to think that everything is only high flow O2 and nothing is breathing for them at all anymore unless you have the BVM. Like the HA was even like discouraging using the BVM at all. They're like, with an amazing, they said something like a really good face seal was the only way you could do it. And I'm like,
which is like guaranteed 2 people on that one specific airway.
Yeah.
It's very difficult to do an EC clamp and actually get a proper seal.
Yeah. Well, they actually said, they were saying that you should jump straight to ET tubes no matter what. Then from there, they were saying after the tube, if you can't do that, then at least do some sort of LMA or SGA, because that's going to be a better seal than the BV. Like they were only going down by the seals and not the other way around.
Yeah.
Just like whatever has the best seal that you can flow through a HEPA filter, then the best.
Yeah. We actually just started using iGels, which it seems like it's a little bit better than over the King airway for keeping a seal.
Yeah. We have more physician comments here, actually. Hold on. So first, well, this isn't Christine Rahi. This is Dr. Rahi. Says it seems like the patient who do best are the ones who are not intubated and were the ones who were cannulated for heart lung.
You're talking about ECMO?
I don't know. We'll see if he comments back.
Who are cannulated for heart and lung machines.
Oh, yeah.
Yeah, I've actually, in the ER, I'm seeing a lot of patients. Basically, we're trying not to intubate them as best we can. Cranking up the non-rebreather and the nasal cannula seems to be the best solution for most people, because there's like a 50% mortality rate for intubated COVID patients. It's absolutely insane.
Yeah. Oh, and then Dr. Beneliyahu, hi Aaron, says...
Nice.
So there you go. Yale's using it. And then he also asked a question about the HEPA filter. Are you placing the HEPA filter? Where are you placing the HEPA filter? It should be placed on an exploratory limb.
It's
the exhalation part, which is off to the side.
Is this for the BVM?
Yeah,
for the BVM, in between the BVM mask and the BVM itself.
Yeah. Oh, really? You're doing it between the really? Okay. Yeah. The ones that I were seeing were going on the actual. So you know how we have the valve on the side, so it stops air from coming back in, and sometimes they'll put a PEEP valve on that if they have someone who they've already intubated. So I was putting it there on the exhalation port. I saw some that were being installed on that piece.
Yeah, let me double check that, but I'm pretty sure that was our guidance by our medical directors.
Well, I mean, it doesn't really matter either way, right? Like, either way, it's still between the patient and all the apparatus that you're using. So
yeah,
it would be fine.
Yeah. That's basically the most amount of sterility that you can manage is basically the goal.
Right. Exactly. Yeah. So that was that one. All right. So I guess moving on to the really hot button one of today. So some of you may or may not know this. So I'll do a recap first. So first, New York State comes out with the protocol around CPR in general, which is that if a BLS provider shows up to the scene and, so let me rephrase. You show up to someone who is potentially in cardiac arrest, you confirm that there's no pulse, and then you attach for a BLS provider an AED. If the AED says shock advised, then you run the code. If it says no shock advised, you don't even start.
Right.
For ALS, if it's your asystole, then don't do anything. If you're PEA, VF, or VT, run the code. Either way, if you don't get ROSC, you never transport. And either way, with any of those scenarios, if you start the cardiac arrest, when you get to 20 minutes in, then you just stop, right? And if you don't get anything by 20 minutes, then you stop. And
you can if you want to.
Okay.
You don't actually have to stop at the 20 minutes mark. It's not a hard and fast rule. If you believe, and Dr. Daly put this out at the Remo medical advisor, that if you get to the 20-minute mark and you feel that the patient is still viable, then you can continue working them up if you wish.
Okay. I didn't see that part of it, but okay. And a
YouTube video, right? What you're referring to? That? Yeah, I think that was a YouTube video that
yes. Right. So anyway, so this protocol comes out. It's fine. It's all working. And New York City even puts out a protocol that says the exact same, that has one page at the beginning followed by the New York State protocol on page 2. Then 2 days ago, this comes out. So I'm just going to make this the big image on the screen for a second here. This really amazing article comes out that shows that. Let them die, but NYC medics vow to keep trying to revive. And then state's shocking new guideline for EMS during virus crisis, no pulse, no CPR. So then that comes out. After that comes out, I'll bring everyone back. Then I think 24 hours go by and that goes away. And then, and then somehow that newspaper gets in touch with the state. However, I don't know. And then this article comes out. Of it, and then that disappeared. And then all of a sudden we get the protocol, right? We get the protocol that came out today from yesterday that says all this. And that is the recap of what happened. So over something like
Sorry, what was the protocol that got released today?
So the protocol that got released today says...
they basically rescinded it.
From the system.
They did.
It's a direct rescinding of don't resuscitate patients that are in asystole.
Right. So the exact quote, which I find is very interesting, is this. Let me put it in here. I think I can drop a quote in here. which is the guidance proposed by physician leaders of the EMS Regional Medical Council system. This comes out like crap. I'll just read it. System and the State Advisory Council, in accordance with the AHA and based on American College of Emergency Physicians, states, hold on, sorry, this is a little jankier than I would have liked. So the guidance, I'm going to turn that part off. So it pretty much says that the guidance proposed is the national standard guidance used by everyone else, right? And then regardless of that, it then goes right in accordance with, we've been doing this in accordance with the AHA and the American College of Emergency Physicians and adopted in multiple other states, reflected nationally recognized, and that's reflecting the nationally recognized minimum standards. However, after further review, it has been determined that these standards are not necessary. And for that reason, DOH Commissioner Dr. Howard Zucker has ordered them to be rescinded. So I think this is the first time I've ever seen within, what, 72 hours, 96-hour window, something going, well, sorry. So the original protocol came out a little bit ago, right?
Yeah.
And then within the last 3 days, it again went from newspaper coverage, no one did anything, second newspaper coverage that implied a protocol was pulled, which it hadn't been yet, to now the protocol's pulled.
Right.
That was a lot of training and in-servicing in my organization that we just got rid of.
Yeah. in like, a good 72 hours.
Yeah. So Arash asks, sorry, we're getting a lot of pings from our physicians friends. So the guideline that they're talking about, Arash, is that it's not, so it wasn't a lot. I wouldn't say that anyone here is at fault. I would say that the guideline was the AHA released about 2 weeks ago, a cardiac arrest recommendation update. And what that update said, among numerous things, was like really focusing on some of the stuff we talked about around airway and just like ventilation and making sure nothing got out. But then it also started talking about like, you should really assess whether or not you should be working up the patient in the first place based on both the risk it's putting to the provider and those providers being placed out of service on one end. And on the other end being bringing a body to the hospital. And third, like working up a cardiac arrest in this scenario not only has really low survivability rates, but also has the ability to be the most exposure-filled thing that you could do to anyone in healthcare, right? You are pumping on their chest. It is pumping this stuff out. You're possibly aerosolizing it through a BVM. And so that was what led to the state and then the counties implementing all these protocols statewide. And so then all this newspaper stuff happened and it went from there. So yeah, did you do an in-service, Mark, on this stuff?
Yeah, we did.
Because I know Jay and I did our official in-service and then we did our unofficial in-service where we just talked about it for a while.
Yeah.
Our little ALS group within our own organization. But how crazy was, well, you in-service probably at both of your places, right?
Just I actually haven't been at Once Levittown in a while.
Oh, okay.
Yeah, I've been, see, the funny thing about that is like, if I get sick, then I want to be able to say like, it's probably from this one location where I work at versus someone else. It's a little bit of protecting myself.
Yeah. Jay, did you run any arrests yet since?
I have not.
Okay. Yeah.
My sister ran an arrest.
One of my other friends that I spoke about, Matt, ran an arrest, and then like the next day this AHA stuff came out, and then a week after the protocol came out. But luckily he hasn't had any symptoms yet. But yeah, it's still crazy. Jay, what do you think about, like, well, I mean, from your standpoint, you were talking to me about it before, like, what do you think about the whole thing? With like the initial recommendation.
Right? I think that if you look at the actual title of what we're practicing under right now, it's a viral pandemic triage protocol, right? And so the concept of triage has always existed. I think that if we look at the events that are unfolding as a mass casualty event, which is essentially what this is, right? It's a rolling mass casualty event. These protocols already exist with START triage, right? So if you have a patient that is apneic, you attempt to realign their airway, and that is enough to be black carded on the START triage technique system, right? Under that methodology, that patient's going to be pronounced. And so I think if anything, this is even more giving more resuscitation attempts to these patients than what could have been implemented to a certain extent.
Yeah. Yeah, definitely. I was kind of happy. The first time Jay and I ever implemented some sort of MCI thing back in the day, I'm sure you know what I'm going to talk about, is like the time we had the microburst. Remember we were talking about the fact that we'd be triaging like over. Mark, do you remember this when our town got hit with the microburst?
Vaguely. This is like
so
4 or 5 years ago.
Jay and I were off to paramedic school that day. We had like class that night, and then it just out of nowhere, just nightmare scenario. And there were so many calls coming in at once. Jay messed up his ambulance to no end. But like when it came in, the whole concept that we talked about afterwards, when we reflected on it, was like, we should have been going to the first call that came in. This should have been declared as one citywide MCI, right? One townwide MCI. And it should have been that we were triaging everyone over the phone. We were literally carding them if we had to go to the scene and assess them, right? With our start triage protocols, then we were moving on. And it's kind of interesting to see that they're trying to impose that statewide here. And I'm not to the same extent, but similar.
Well, they're doing most of that in Suffolk County now. They implemented the disaster level 1 for Suffolk County, where if you call with COVID-like symptoms and they're not severe, they'll put you into the system under surveillance. And then if it gets to the point where it's much worse, they'll go to a level 2, and then instead of you being triaged at an alpha level and not getting an ambulance, you can be triaged at a Bravo level and not getting an ambulance. So your symptoms will be worse, but you still won't be going to the hospital.
Right. Yeah,
they won't even send an ambulance to you. They won't even notify the department, which is actually, it's okay. I mean, if they call back later on, we'll send an ambulance. If it comes down to it, like your symptoms are so bad that you do warrant an ambulance at that point, then yeah, because otherwise the healthcare system would be inundated.
Yeah, I got the notification today actually that the city was doing something where they were now like they outsourced or they were using a medical software company that was doing One Medical, I think it is, that's helping them with like stay at home like consultancy and care. Because I got a push notification today on my phone for like New York City like civilian emergency notification line. I was like, hey, like if you're feeling sick, just go to this website or call this number, and they'll take you to One Medical, and they'll tell you if you need to see an ambulance or not.
I mean, this is like a pretty good example for having community paramedicine in New York State.
They've been talking about that a lot. Have you been hearing?
I have not. I mean, the last thing I heard about it was that it was killed in committee at the state Senate level in like 2016.
Yeah, well, I think if this keeps going on, it's gonna. I mean, they're talking about doing testing in person and like all this other stuff as well, and they're talking about like sending EMTs out into the field to apply tests. And I haven't heard anything of this actually getting implemented, but like I know they're already saying it just for the one situation right now, which is, you know, if you feel like you have flu-like symptoms and you want to go. But I wonder if based on how long this goes on for, if this is going to keep getting more and more along those lines.
I mean, for some extent, this is combat medicine, where we're going to learn so much about our system and where the weaknesses are, especially when it's under load. You get to see where all the cracks are starting to appear. So this is one of the cracks. Like we don't have enough providers in order to go to all of these houses. We definitely don't have enough ambulances.
I think there's two things worth like touching upon. The first is that, like going back to what we were talking about before, there's definitely going to be an exacerbation of underlying medical issues with people not being able to routinely to see their providers regularly anymore because they just aren't open or everything's shut down and they can't get there. Something along those lines will happen, and that's kind of where a community paramedic would be able to step in and prevent that event from getting as bad as to the point where they'll need to go to the hospital and be treated inpatient. The other aspect, I think, is that you can't just create community paramedics without having that reflected and incorporated into the education system for paramedics to begin with, right? So I don't think that any of us could jump in to serve at the level of a community paramedic without doing either some kind of supplementation or having a systemic change within the paramedic education system in New York State. I have a friend who I have a friend in medical school with me who's a community paramedic up in like the territories in Canada, and her knowledge base is insane. She was trained to a very different level than what we were because so she had to do it in it was a legit undergrad 4 years, and she was trained accordingly, right? And so she was able to fill that role because she was prepared for it and educated for it. And so I think we'd have to see that matched in the New York system before we could kind of jump to that sophisticated level of practice.
Yeah, there also isn't like a standardized CC medic program anywhere anyway. So like,
right, we're kind of just like so Blocker and I actually did the CC medic program together, essentially through shock trauma, right? It was through like sorry,
UMBC.
Yeah, and so it's kind of just like they set the standard by being the only program that exists, which is very strange. And so it's kind of like we had a weird, like the failure rate in our program was ridiculously high. We took it at different times, but I think I was one of I think only a quarter of our class passed. This is like out of 40, 50 medics, only like a quarter of us passed. And it was primarily because the people who were teaching the curriculum had never taught or touched the curriculum before. It was a mix of physicians from our local healthcare system trying to like teach someone else's curriculum that was just imported here because we don't have a standardized education system for it. And so I think that that's another place that definitely is worth, looking at, because obviously a lot of this is critical care medicine that we're talking
about. I also wonder how much of it's gonna, like they were even talking about, I wonder if it's gonna become part of the overall narrative, even BLS. And I'm not saying it, I'm not advocating for it, but like the different levels of things that EMS needs to do in the field, how much of it is going to be, how much of it is like administer the test and bring it back, or, someone needs like a BLS assessment on something and left versus ALS. Because I'm seeing, I forget if the city's done it yet or whoever, but I know there's somewhere where they're moving from dual medic ambulances to single medic ambulances just to spread the medics out more.
The hybrid model.
Yeah, and they're like really pushing this. And I think there was even some changes done that talked about the fact that you could now integrate CFRs, a CFR EMT role, a CFR and EMT was considered BLS.
That
was considered BLS, and like they're just trying to stretch it out. And although they're bringing a lot of people back on the nursing side back into the field and all of that, have you heard of anyone coming back into the field, like reviving their paramedic? And I don't mean like a year ago or 2 years ago, because that's what the state's doing now. But I'm like, that's just getting the card back. But getting into these organizations, like, hey, I haven't been a medic in 15 years, but I'm ready to rejoin the workforce. Let me hop on your ambulance. Like, I don't see that.
Well, okay. Well, that's a hot button topic. It depends on the medic and where they got their experience from, and like 15 years is a really long time.
Yeah.
So, I would be very, very cautious about having them on the ambulance without direct supervision for a significant amount of time, because you would have to go through like a whole internship again. But at the same time, the state certification, you still have to go through the skills exam. You still have to pass a written test in order to get your card back. Mm-hmm. And then afterwards go through field training.
And for ALS, with your employer, you have to pass the county level as well.
Yeah.
So like, it's an extra, it's not even like the organization can just kind of whisk you through the whole thing.
Yeah.
Like, or one state card gets it done. Now it's like, I don't know in New York City if they're fast tracking, like getting new city MAC cards or something for people.
No, I don't think so. I don't think the situation has gotten that dire. Although they did put out an FDNY ops order, I think it was, where they were putting paramedics with an EMT partner in order to facilitate having more ALS units. And then on the same side, because they had lost so many people out sick, that they were putting CFRs with EMTs in order to make a BLS unit.
Yeah. Yeah, and I guess kind of going back to the whole community paramedic part, like Jay's talking about, regardless of all my training, like I'm sure for all of us, I know stabilization, I know assessment. I don't feel that comfortable taking someone and being like, I've completely treated you and you're fine and stay home and I'm going to go. Right. I know when it's not bad enough, but like, as far as what care they should get for a while. Like afterwards, like, oh, you got this cut or you got this injury, let me patch it for you. And then you're expected to do, like make sure it doesn't get infected and call me like if something like, I don't know. Like
going back to the education concept, I mean, paramedics aren't trained for anything other than high acuity and short-term management, right? So treating someone for the long term is just not what we're trained for. It's not within our skill set or knowledge base.
Yeah. And I know a lot of dispatch centers, and I know Northwell's doing a lot of stuff around this, and there's this whole ET3 thing now. I wonder what's going to happen with EMS so Jay, I don't know if you heard about this. So there's a concept now about taking EMS providers and having them say they can transport patients to other places than hospitals.
Yeah.
So urgent care.
Alternative destinations.
Sorry, what'd you say, Mark?
Alternative destinations.
Yeah, yeah. And so I know in Muru we've been like seeing how we're going to integrate that into the current hospital section of our app if it becomes something that they want EMS to do. Because I mean, EMS providers can memorize all they want about every hospital in the area, but like how are they going to start knowing all those locations and picking that information out? So, but I think that's maybe where it's going to go, right? Because if the education doesn't have what it needs, like if you're not educated and if you're not educated to be able to do this section of it, but you are educated to assess, stabilize, and transport, then it's just talking about transporting somewhere else.
Well, yeah, but I also think that you're going to have medical control still. So, like, if you have a question, you can always get on the line with medical control and be like, I'm not really sure what to do here, just like we do in the back of an ambulance anyway when we come to that situation where we can ask questions. But there's also the fact that community paramedicine would be an add-on certification like flight medic or critical care paramedic.
Yeah, definitely. Yeah, but it's crazy. Has there been any other change that you've been seeing, like as far as any of the other protocols or anything else that we didn't talk about?
The guidance was actually for leaving patients where you found them. They had also put a third part into that protocol where alternate destinations were a possibility, but they were not yet activated. So we're still like looking at that and wondering like, is this going to be a thing in the near future? Because I mean, potentially we're at the peak of the first wave, and there's a potential second wave that could be even worse.
Yeah. What do you think about the second wave part, Jay?
I think there's a lot that's unknown about the natural history of the pathogen, and so the ability to forecast how this will play out is really up in the air. There's a lot of uncertainty that surrounds it, and that's what's most terrifying about this.
Everyone's supposed to guess.
Definitely. How's it been with the BLS ALS transport? Like the BLS, if it's a BLS ALS unit, are you ever sending the EMT in while the ALS person stays out, or is it always the ALS person going in for the assessment?
It's almost always the ALS person doing the assessment, simply because they have a lot more tools at their disposal.
Yeah.
I also think that the assumption is that it's going to be a respiratory call. It's a respiratory compromised patient. So inherently that requires the assessment of a provider at the level of a paramedic.
Yeah, and I'm also just trying to isolate my partners for the most part. We've isolated the cabin, the chauffeur compartment of the ambulance, in order to make sure that no one who's not directly involved with patient care doesn't get exposed. And
2 happy bags of duct tape, but I'm not advocating for that. I'm just saying.
I mean, that's basically what we've done, because there's no situation in the past where we ever thought that we would have to separate the compartments like this for this reason.
Yeah. Yeah, it's always been a sound thing or something else. It's never been privacy. It's never been this sort of like airtight seal.
Yeah. I mean, there are like pods for stretchers where you basically entirely encapsulate a patient in a pod. So I've seen that, but not in the 911 setting. That's basically always for the interfacility setting.
So now you have to like reach in with the crazy like mitts and
yeah.
All right, neonatal units for adult people.
Yeah, it's a lot more malleable plastic than that, but yeah, pretty much.
Oh, here. Oh, hey, Gus. Gus says they installed plexiglass units down where he is. He's not different state now. He's down south from us.
Okay. Yeah,
But
I mean, anything that you can do to isolate whoever you can from the patient compartment is probably a good thing.
yeah,
Because in the back of the ambulance, we're like turning on the vents to the maximum setting, putting the air conditioning on in order to like wash it to the back of the ambulance.
yeah. Well, speaking of vent, did you see also in the HA protocol? They sorry to bounce back to it, but they talked about like not only using the auto compressors but using ventilators. I think as Jay and I remember from when we first saw the disposable ones years and years ago, the disposable what was it called? What was it?
Oh, you mean the ones that attach to the oxygen supply and doing automatic ventilation, right?
In addition to like an actual ventilator with like PEEP settings and everything else, just the little one to remove one more person from being near the head, physically squeezing the BVM.
Right.
It's like, and then it's like, all right, now I just, I push medicine and I.
Was that like an idea in a cardiac arrest situation?
Yeah, we were talking about, well, Jay, you were a bigger fan of it. Why don't you say?
It's just an automatic ventilator. Regardless of the call, it's whenever it was medically indicated, it was just another tool at our disposal that we wanted to have access to. It was really cheap. It was like a few bucks, and they were completely FDA approved and everything. I don't know, why didn't we end up getting them? I can't remember.
I think you and I were. I think we
were exited office around there.
I think we were at the cusp of when we were done being officers at the organization.
Yeah.
So,
when you say a few bucks, how much do you mean?
This was almost 10 years ago. So I imagine the price would have gone down, if anything, but that's also a bad assumption.
Is it less than $100? Like, what are we talking about?
It was like disposable. It was a one-time use. It wasn't like an IO needle or anything. It was.
I think the mechanics of it was basically that it built up enough pressure within the unit from the supply of like oxygen to administer like one positive like ventilation puff, and then it would reset and then try to create enough positive pressure until like it released again, and then it would ventilate again, and that was how it worked.
I'm super interested in this. Like, what kind of rate are you getting out of this? What kind of volume?
It was very.
Can you use it with a Lucas?
It was I have no idea how that would work with the Lucas. This was pre-Lucas. Lucas were not even a thought in our mind at that point. But yeah, it was just something that we thought about. I think we had a really bad COPD exacerbation that we ended up intubating or something like that. And I think we were like bagging the patient for like 20 minutes, and that's why it came up as a conversation. And we looked into it, and there was definitely a product that existed, but we just never followed through with it.
Yeah, this was back when only who made the original auto? Not Lucas, the other auto compressor from like with the band.
Zoll?
Yeah,
Zoll was
Yeah, Zoll was like from a long time ago. They've been out for a really long time, way longer than the Lucas. But I remember between that and that vent, it was kind of like, okay, well, once you have everyone set up, you don't really need like.
Yeah, it's just the medic in the back pushing the meds.
Yeah, like giving one person plus myself, and I'm more than enough people in the back of the ambulance now to run an entire code.
Yeah, that's the holy grail of cardiac arrest in an EMS setting.
Yeah. Yes, thank you, Gus. Gus wanted to remind us that it's called the auto pulse. Thank you. In a minute from now, by the way, he's also going to find the disposable.
Oh, nice.
And slip it in.
If he does find it, please post it. I would love to see that.
So yeah, but so I remember all that stuff it was kind of a cool setup, and I guess that was just for us to reduce the number of people that we needed on a call. But now in particular, it's totally changed to you actually need to reduce the number of people in the back, and what's every possible way you can do that.
Yeah, well, that's my problem with putting like I would love to be able to put my vent on patients in cardiac arrest, but my vent is going to be pressure activated. And even with a volume control, it's probably just going to freak out the fact that it's getting pressure back from the vent pushing down on their chest. So there's like no good way to do it as far as I know. And if someone knows a way to do it with the Revel ventilators, I would love to hear it, because that would be the holy grail of cardiac arrest.
Yeah. So let me ask you one last question while we're on the cardiac arrest subject. How often, since this is something Jay and I have never done exactly the same, how often do you work the patient at scene until you either get ROSC or you terminate?
Well, I've never worked in a healthcare system that actually allowed that, except for New York City when I wasn't a medic. So
wait, we're in Nassau County now.
Yeah, I'm in Nassau County now, but I haven't actually done an arrest here with that capability yet.
No, pre-COVID.
Oh, pre-COVID? No, I haven't. I haven't done an arrest in Nassau County in probably 2 years.
Wow. Okay. What's really funny is if you looked at the state protocol in general, right before this thing came out with COVID, they moved EMS, BLS, and ALS to no transport cardiac arrest to the hospital. Like they removed it in general, but because we adopted the collaborative protocols so shortly after, so quickly, just before COVID came in, I think it all got swept up together. And kind of going back to our original part of the conversation, where we were bringing up like, what's it going to be like when this gets dismantled later with RMAs and everything, or sorry, not RMAs. I think it's the same thing with cardiac arrest here, right? Like there is a state protocol there is the collaborative protocol BLS version that is flat out saying that after 20 minutes, you call medical control to get permission to transport to the hospital if you don't have ROSC.
Yeah, I think medics can just call it at that point. If the 20 minutes mark and you don't have ROSC, you can just be like, well, sorry.
Yeah, but it's crazy, right? Like that's still, I bet you there's going to be a lot of protocol confusion around that because it got implemented maybe a month and a half before we start seeing a lot of changes around COVID, and now they're going to dismantle it. And I bet you, I mean, it would happen to many people I know, right? That it's just they're going to attach those two things together and not remember to separate to disjoint the two concepts, right? Of that you're still not transporting to the hospital unless you call in. And
yeah, that has been a protocol for quite a while, and it's been protocol in other states for even longer.
Yeah, the 20-minute marker in particular. So that's cool. All right, well, yeah. Okay, well, I think that concludes this chat. Thank you for both participating. Jay, Mark, I more than appreciate you guys taking the time to chat with everyone about this. I hope everyone who saw it got a good chance to just get some of this off their chest and listen to just a bunch of people talking about the protocol changes that happened, and we should do this again sometime.
Yep, definitely.
All right, I will video chat you guys soon and talk to you later. All right, thanks everyone.